So we'll start.
Yeah, sure.
Good afternoon, everyone. Welcome back to our Department of Medicine academic feast. We have with us Dr. John Jones back again on these topics on critical care medicine. Today we have a discussion on cardiovascular physiology and approach to shock, part one. The second part will be taken tomorrow at 12 p.m. Prior to the lecture, sir will also discuss the ABG quiz answers for questions 11 to 15. If any doubts, please feel free to ask. You can unmute yourselves, ask permission to unmute yourself, or can drop down your questions in the chat box. You can either otherwise also mail your questions to med2@cmcvellore.ac.in mail or contact us for any further queries. This lecture will be recorded and soon uploaded in our Department of Medicine YouTube website. Thanks again, sir, for agreeing to take this lecture for us. Over to you, sir.
Welcome. Good afternoon, everybody. We start off with the ABG quiz answers before proceeding to the section on shock, where I'll deal with the basic concepts in this lecture, and tomorrow we'll deal with the management. Okay, this is patient 11. Diagnosis is his PO2 is very high, but his PF ratio is poor. You can calculate the FiO2 based on the formula given, 2.5% for every liter per minute of flow, added on to what is present in air already. You will find that it is PF ratio is poor. The metabolic, he's got acute respiratory acidosis. It's because obese patient, maybe he had obstructive sleep apnea, and too much oxygen will make them hypoventilate. And if you look at the metabolic status, the base excess is negative, whereas it should be with an acute CO2 retention be 0. Chronic CO2 retention should be positive. This actually got negative. So it's obviously got a metabolic acidosis superimposed. So that is the complete diagnosis for patient number 11. Patient 12. Oxygenation is appropriate. PF ratio is low. It's on 50%, 0.5 FiO2. Metabolic diagnosis is a chronic smoker, probably COPD. So he's got some amount of chronic respiratory failure because he's got a metabolic alkalosis, because he may having a chronic carbon dioxide retention, on top of which his pH has become acidotic. So he's got an acute and chronic respiratory acidosis. Base excess is elevated. And you can calculate the base excess elevation depending on the CO2 rise. Chronic carbon dioxide retention, which is 40% of the rise. So when you actually calculate rise, one of the questions some people ask is, where do you take the CO2 from? So generally I say that if you are going to take a rise in CO2, take it from the upper end of the normal range. So 45 to 68. If it's a drop, you take it from the lower end of the normal range. That is if you don't have a previous blood gas for the patient. If you have a previous blood gas for the patient, you can take it from whatever his value was when he was stable. In the absence of such a value, you will rise from the top of the normal range and fall from the bottom of the normal range. So that is patient 12. Patient 13, hypoxic, 45 only oxygen, reduced PF ratio. Definitely got cor pulmonale. He's got a chronic respiratory acidosis. You look at his base excess, it's highly positive. On top of that, his base excess is higher than you expect for that carbon dioxide rise. So he's got a metabolic alkalosis on top. And this is unlike the previous patient, his base excess is positive. So he's got chronic respiratory acidosis as well as a metabolic alkalosis, because his expected base excess is higher than what you would expect for a CO2 of 77.5. Maybe related to his use of furosemide. But if you notice, the pH is within normal range because he's got two disorders pulling in opposite directions. This is a patient who comes with a gastroenteritis and sepsis. Oxygenation is fine. PF ratio is reduced. He's definitely got a metabolic acidosis. Because he's got a high lactate. Remember when I said acidosis is the process which is trying to change the pH. pH may actually become normal because there may be 2 or 3 disorders which are competing for the pH. So his lactate is high, it's 13.7, and his SID is 58. If you look at the sodium, 154, chloride is 96, that's 58. And if you look at it, that's interesting. That should cause an alkalosis, and that has actually buffered the rise in lactate, so the pH remains normal. The lactate remains hidden unless you do a lactate separately, which most blood gas machines do nowadays. And he's also got a respiratory acidosis because the CO2 is higher than what you would expect for the pH, 34. So he may be going into respiratory failure. Top of it is PF ratio is poor. Maybe he's going into early ARDS. I mean, you can think of anything, but just be aware that the CO2 is higher than you would expect for a pH of 7.34 in a patient with metabolic acidosis. Number 15, the last for this session is hyperoxic. His oxygenation is too much. PF ratio is fine. Got a respiratory acidosis. Oops, sorry. And a metabolic acidosis. Base X is minus 90. But the metabolic acidosis is not explained by the lactate level or the SID. So he's probably got some extra ions which is causing more metabolic acidosis. Maybe he's got renal failure, post-cardiac arrest. So he's also got some ions retained because of his renal failure. We don't have a creatinine here, so you can't comment more on that. But definitely his keto acid should also be checked because his glucose is 22.9. So that's it for the 5 APGs for today. Rather than the last 5, I will discuss tomorrow. Any questions on this?
Any questions, please? If anyone want to unmute yourselves, please.
Anyway, this will all be sent to you. You can also ask me tomorrow's session also. That's fine.
Sure. As of now, no questions, sir.
Okay, so we'll go on to the basic hemodynamics
Sure.
concepts in shock. Now, definition of shock is that it's an acute syndrome. There's nothing called chronic shock. It's systemic. It does not affect just one part of the body. An ischemic leg is not shock. Of course, it can become infected and cause shock, but by its local organ ischemia is not shock. It's initiated by ineffective tissue perfusion and results in severe dysfunction of organs which are vital for survival. So that is what shock is. It is an acute systemic clinical syndrome initiated by ineffective tissue perfusion, resulting in severe dysfunction of organs vital for survival. Now, if you look at a schematic diagram of the circulatory system, you have a pump which pumps fluid through blood vessels, carrying nutrients, oxygen to the tissues, and bringing back waste products and carbon dioxide. At the simplest level, any of these which are affected can give rise to cardiovascular failure, which is basically what shock is. You can see it is analogous to an electrical circuit where you have the cell, you have the resistance, and you have the wires. It is not exactly the same, but you can compare it to an electrical circuit. And that's what they actually did in the olden days when they were using the PA catheter to measure peripheral resistance. Now, just a word about the heart. The heart gets blood from a low pressure system and pumps it into a high pressure system. It cannot suck blood into the right atrium. It can only allow the blood to flow. Its ability to generate negative pressure is limited. I mean, it's not there. Unless the lungs you expand, The chest expands and creates negative pressure in the thoracic cavity. The heart by itself cannot suck any blood. And the purpose of it, the pumping action, is to meet the needs of the tissues. Sometimes we focus on the heart and ignore the tissues, but the whole idea of the heart is to pump blood to meet the needs of the tissues. So it's a slave, not a ruler. Now let's see what the blood contains in terms of oxygen. The 1.34 ml of oxygen is bound to every gram of hemoglobin at 100% saturation. And if you multiply that by the cardiac output, which is in liters per minute, but the hemoglobin is in grams per 100 ml, so you have to do a small mathematical twist there. You will get the amount of oxygen which is in the blood, reaching the tissues every minute. So here we're taking 1.34 ml of oxygen per gram of hemoglobin, 15 grams of hemoglobin, 100% saturation, cardiac output of 5 liters per minute. But because the hemoglobin is in 100 ml, we divide it by 100. The oxygen delivery is 1000 ml a minute. The consumption is 250 ml per minute. That's what the basal. Of course, if you're sick or you're running, you need much more. So the oxygen extraction is 25%. 0.25 is the oxygen extraction. So there's a lot of buffer for oxygen. I mean, not a lot, but enough. And remember that in the previous equation, there are 3 variables and 1 constant. So if the variables change, you can adjust the constant to some extent, in the sense that the cardiac output can increase for a drop in hemoglobin, or for a chronic drop in cardiac output, the hemoglobin can increase. But you can't, of course, go up on the saturation more than 100%. So there is limits of compensation. Carbon dioxide production is, a basal situation is 200 ml per minute. Now let us look at the blood glucose. Say we take an average of 100 milligrams %. Cardiac output is 5 liters. So the delivery will be 5000 milligrams per minute. The consumption is 2 to 4 milligram per kilogram per minute. If you take that for a 70 kilo person, you would find that the amount of glucose delivery far exceeds the amount of oxygen delivery, the amount of buffer of glucose. So in a way, oxygen is a critical component which will be affected when the cardiac output reaches a critical level. And the brain is very sensitive to hypoxia. So, and hypoxic brain damage is irreversible. The brain, of course, needs glucose, but there's a little more glucose buffer than oxygen buffer in the blood. Comparing the arterial and venous, PO2 is 95 and 40, SO2 saturation 100 and 75, PCO2 is 40 and 46. Glucose difference is around 3 to 4 milligrams %. Just to compare the two sides of the circulation. Now let us look at some of the parameters which we measure. The blood pressure. We measure the systolic, which is the highest, and the diastolic, which is lowest. And the mean arterial pressure, which is actually a perfusion pressure to the tissues, which is closer to the diastolic because the more time is spent in diastole than in systole. So on an average, twice the amount of time is in diastole as in systole. So if you do the calculation, you need a mean of about 70 to perfuse the tissues in normal persons. But if you are chronic hypertensive or you got atherosclerotic disease, you will need a higher mean pressure. Quite often you will find patients atherosclerotic disease coming back after major surgery from the OT. Systolic and diastolic, you do the mean, it's 70, but that may not be enough for them. In such patients, you may have to maintain a higher mean to ensure he doesn't go into renal failure. Now, basically, the blood pressure depends on the cardiac output and the systemic resistance. And there is variation in blood pressure. This affects the systolic more than the diastolic or the mean arterial pressure. Now, if you look at the flow, you've got an artery, vein on the other side, and resistance vessels in between. Flow depends on the difference in pressure divided by the resistance. And just a word about the arterial pressure measurement. You can use the cuff method. I mean, you use an ordinary BP cuff, you can hear the Korotkoff sounds. That actually measures the flow. But if you put an intra-arterial cannula, that measures pressure directly. And of course, flow is proportional to pressure if resistance is within certain limits. However, when the resistance changes, the relationship changes. Just to give you an imaginative example, if you tie the brachial artery and put a cannula above the tie, you would find good pressures. But if you measure flow, there's no flow below the tie. If you cut the vessel, flow is free, but there would be hardly any pressure. Drop would be tremendous. So in other words, when the resistance changes, for instance, when there is severe peripheral vasodilatation, like in sepsis, you would find that your big discrepancy between a cuff, non-invasive blood pressure measurement and an intra-arterial cannula measurement. So keep this in mind while you're interpreting the blood pressure. Now on to the venous side. If you look at the venous pressures and the blood volume, the rise in venous pressure is not a straight line, it's a curve. It rises very slowly when it's fully collapsed, and then slowly it starts rising and then rises very steeply towards the end. So low CVP is less than 5, high is more than 15. But CVP, though it was used commonly, has fallen into disfavor. Before I come to that, I will just say that the CVP is like inflating a tire. Initial inflation, there's hardly any rise in pressure. And as you keep on inflating, it rises very sharply. Now, why don't we use the CVP? This is a study which was done a few years ago and then recorded the blood volume and the CVP, and you found it's a random plot. So the CVP doesn't correspond very well with the blood volume. So CVP was discarded as a measure of the blood volume status. And other measures were brought in. I'll deal with this in tomorrow's lecture. But just remember, CVP is a measurement, does not reflect the blood volume accurately. But it tells you something else. I'll come to that a bit later. When you think of the vascular system, think of two types of volumes, unstressed and stressed volumes. As I showed you the example of the tire, when you first start inflating the tire, first there is no increase in pressure. This is equivalent to the unstressed volume in the cardiovascular system. It just fills the system without causing any rise in pressure. And after some time, the pressure starts increasing. That is the stressed volume. As the fluid starts distending the walls of its container. And this is where I would bring in the concept of a mean circulatory filling pressure. Just to take the analogy of a bathtub, you have a bathtub into which you are draining water, and from which water is coming out. The height of the water column below the draining pipe contributes nothing to the flow out of the drain pipe. It is just there. That is the unstressed volume. It is not to scale. This is just to give you a concept. The stressed volume is actually the height of the water column above the draining tube, and that is what pushes water out. And that is what causes the venous return. Is a stressed volume in the venous system, which pushes blood into the right atrium. But of course, this is opposed by right atrial pressure. So in a way, a high CVP will prevent this drainage. And what the heart does not receive, it cannot pump out. Now, the mean circulatory pressure is the hydrostatic pressure in the circulatory system when there is no flow. This is a theoretical concept. Unfortunately, we don't have any way to measure this. But remember, it depends on the stressing volume of the circulation. When fluid is given beyond the unstressed volume, pressure will rise and venous return will increase. But in an ordinary situation where there is no dilatation of the bed, the value of this is about 7 millimeters mercury. There are connected terms called mean circulatory systemic pressure, but I wouldn't go into that. Just mentioning it, know that don't get confused. We're talking about of the entire circulatory system. Now, this diagram must be familiar to all of you. The cardiac contraction curves, preload and stroke volume. As you increase the preload, as you distend the ventricles, the stroke volume increases and then flattens out. Unless you increase the contractility by using inotropes. So there are a family of Frank-Starling curves. between preload and stroke volume depending on the contractility, which you can change with inotropes. This is a familiar curve, and this is what you try to do by increasing cardiac output. But there is another family of curves known as the venous return curves. As the venous right atrial pressure goes up, beyond a certain level, the venous return actually drops because there's more resistance to venous return. The heart can only pump out what it receives. It cannot suck in blood from the peripheral circulation. So the cardiac output is at the intersection of these two curves. Your Frank-Starling curves, which tells you preload and output, and the venous return curves. So it is an intersection of these curves that you get an actual cardiac output. So a very high CVP with a low contractility will give you a very poor cardiac output. In a nutshell, MAP, depending on stroke volume, heart rate, arterial resistance, decides tissue perfusion. Venous return depends on your RA pressure and your mean circulatory filling pressure, which depends on your stressing volume. What are the effects of shock? Tissues have decreased perfusion, anaerobic metabolism, lactic acidosis, leading to tissue dysfunction and organ failure, landing up with multiple organ dysfunction syndrome. But just remember that lactate is not all about perfusion. Lactate needs enzymes, is generated from pyruvate, and pyruvate usually goes onto the Krebs cycle in the presence of adequate substrate and enzymes. Thiamine is an enzyme which is needed by pyruvate to go to the acetyl-CoA pathway. If you have thiamine deficiency, your lactate can go up. Also, lactate is metabolized in the liver. So if you have liver failure, your lactate can go up. So I'm mentioning this just to remember that high lactate does not equal shock all the time. There could be other reasons. Keep your eyes open. Is there liver failure? Is there a thiamine deficiency? Adding on to the lactate. Shock in the heart. The heart has two chambers. The left-sided chamber is under high pressure. The right-sided chamber is a low-pressure chamber. The coronary vessels go into the myocardium. So the right-sided perfusion pressures are adequate throughout systole and diastole. The right heart gets perfused pretty well, but the left heart is perfused only during diastole. So if you have a drop in pressure, like in shock, you have reduced LV perfusion, myocardial dysfunction, more cardiac output is reduced, and becomes a vicious cycle. And finally lands up in a crashed patient. So it's important to push up your blood pressure fast, especially important if you already got coronary vessel disease, which needs a higher perfusion to push the blood through this coronary circulation. Now, what happens to the lungs? This is a figure we had discussed in the last lecture. Excuse me, the spectrum of EQ abnormalities. We have one end, you have collapsed alveoli and perfused vessels. The other side, you have ventilated alveoli and collapsed vessels, which causes a dead space. So in shock, basically what would happen is your alveoli are not perfused. Your dead space increases. So you have a disparity between minute ventilation and carbon dioxide. And this, of course, increases your work of breathing. And remember, the lung at the microcirculation level has got alveoli. The pressure varies between -1 to +1 centimeter. The interstitium has fluid, which has a basic driving pressure of about 1 millimeter mercury. And this is rapidly cleared by the good lymphatics available in the lungs. So the alveoli are kept dry. What happens when your blood pressure drops? Now, if you look at the alveoli, there's a drop of pressure from the apex to the base of the lungs when you stand up, or from anterior to posterior when a person is lying down, of about 20 to 23 millimeters of mercury. So the alveoli at the top are actually underperfused normally because of the gravity. And the alveoli in the middle are perfused intermittently. Alveoli, the bases are well perfused continually. And there is, of course, these are known as West zones. Some people include a fourth zone, which I'm not going into. I mentioned it for completion's sake. So when MAP drops, you would find a shift of zone 3 alveoli to zone 2 and zone 2 to zone 1. In addition to that, you would find decreased perfusion of the respiratory muscles, inadequate oxygen delivery, respiratory muscle fatigue, and leading on to respiratory failure type 2. So all of this contribute to respiratory failure in a person with shock. Kidneys, of course, can have pre-renal failure or ATN. Brain person can be agitated initially because of hypoxia, or then can become obtunded. Now, keeping all that in mind, let us look at the types of shock we can get. Going back to our basic diagram. You can have low fluid, it's called hypovolemic shock. Poor pump action, cardiogenic shock. Change in vascular tone or opening up of shunts. So you have an increased intravascular space, causing a relative hypovolemia, that is vasogenic shock. And you can have obstruction somewhere, giving rise to obstructive shock. Let's look at each of these in a little more detail. Blood volume loss or fluid loss causes volume hypovolemic shock. Cardiogenic shock can be due to acute myocardial infarction or myocarditis or acute valvular lesions. Just a couple of words about some specific situations. When an RV infarct, you would find that the CVP will be high, but the left ventricle will be underfilled. So the treatment in this situation is give more fluids, even if those CVP will be high, so that you increase the MCFP and push more fluid into the left side, then which can pump up. This is in a pure RV infarct. If you do this in an LV infarct, you may find that your lungs are getting flooded. Acute MR can also needs to be urgently corrected surgically. Ruptured wall, nothing you can really do in this situation. It rapidly goes into pericardial tamponade. Vasogenic shock can be septic, anaphylactic, or neurogenic when spinal anesthetists are given. Obstructive shock, I put this separately because the therapy has to be fast in many of these. Like tension pneumothorax, you have to put in an intercostal drain. Pericardial tamponade has to be tapped. Of course, ball valve obstruction, you can't do anything much except change the position of the patient. And massive pulmonary embolism, you have to thrombolize and fill with fluids because you have to get the fluid onto the other side of the heart. Now, those are the 4 basic types of shock, like 3 primary colors or 2 basic types of respiratory failure. But in real life, nothing is pure. It's all mixed. So the idea is with your investigations to tease out which is the predominant component and start therapy appropriately. You can have a cardiogenic with hypovolemic shock and an acute myocardial infarction with excessive diuretic use. Vasogenic with cardiogenic in septic patients with myocardial depression. Vasogenic with hypovolemic in sepsis with gastroenteritis. Hypovolemic and cardiogenic when viral gastroenteritis with myocarditis. Hypovolemic in obstructive dehydration with pulmonary embolism. And many more varieties you can have. So that is for today. Do you have any questions? Tomorrow we'll deal with the management, how we put all this together and get to a basic idea of how to manage these patients in shock. First is the recognition, then is the management.
Any questions?
APG, cardiovascular concepts, any questions?
You can write down your questions chat box. So it really matters now, so that to maintain the map and delay, to make sure that the delay in the perfusion, reperfusion can make a lot of injury, the myocardial dysfunction, which
Yes,
then
yes,
later
correct.
on
Absolutely. We'll
Yeah,
come to that. Tomorrow we will deal with that in detail, but what you said is absolutely right. That map has to be maintained depending on the patient's basal status. It's map for a 20-year-old won't be the same as a map for an 80-year-old.
There's a question. So how to determine the amount of fluid given in patient with previous history of heart failure presenting with sepsis?
I think this belongs to tomorrow's lecture. Just hold your horses till we deal with it tomorrow. Because I have not talked about the management.
We have part 2 to this.
Just hold on for tomorrow. After tomorrow's thing, you ask me that question, I'll put it in perspective.
Tomorrow on this link, we'll have a same link, we'll have a lecture.
The management of shock. This belongs to management. I will deal with all the components of management tomorrow. And you can ask me the same question tomorrow at the end of the lecture. And I can put it into perspective. I want you to get the concepts straight first, then we go on to how we use these concepts to manage shock. Anything on the ABG is crystal clear.
Any questions on ABG?
There's some echo in the system, some microphones.
Any questions? We'll wait for 2 minutes. Anyone wants to type in any questions, please feel free. We have just provided you with the link to the feedback to the lecture. It just takes 8 to 10 seconds to just fill up this form. There's a Google Drive link, just anonymous feedback to the lecture which has been taken today. We'll also put up the mail ID to which we can ask questions, if any further questions, or if you want to get hold of this presentation or the quiz questions, we can mail to med2@cmcvellore.ac.in.
Tomorrow at 12 o'clock, right?
Yes, tomorrow at 12 o'clock, sir.
So the rest of the ABG questions and the rest of shock.
Yeah, so that'll be the last of ABG questions 15 and 20. And we'll have a second part on approach to shock management.
Yeah, management. That's very important.
We'll be uploading this lecture soon in our Department of Medicine YouTube website. So anyone who missed out, please pass on the word that we can be availing this lecture from the website. If no further questions, then we'll wind up for today, sir.
Yep, tomorrow at 12 o'clock.
Yeah, tomorrow at 12 o'clock again.
Yep.
Thank you, sir.